All right, guys, well, welcome to this pharmacology review on the drug class proton pump inhibitors. I'm Dr. Busti, your faculty and host on This Is Why. It is a show that helps healthcare professionals, that transforms their medical knowledge from the what to the why. You know, the PPIs came right after the H2 receptor antagonists, with omeprazole being the first back in the late 1980s. You know, this was followed by lansoprazole. And in my 30-year career working as a nurse, pharmacist, and physician, I've seen this class evolve and even shift from being prescription only to now also having options over the counter. You know, they met the need of what the H2 receptor antagonists couldn't, which leads us to the question, why should we learn about the PPIs? Well, remember, first and foremost, they have a long history. They're overcoming something really important that was a limitation of the H2 receptor antagonist, and that is tolerance. They're also able to achieve greater reductions in gastric acid production that change the pH above 4 and even get above 6 for longer periods of time. They have good pharmacokinetic profiles that allow for easy once-a-day dosing. They're available orally, and we also have options for parenteral or IV administration for the acute care. So that gives us an option for both outpatient and inpatient environments. That's good for patients, but it's also good for us as clinicians, especially needing options. So now, what are the medications that make up this drug class? Well, it's evolved over time and grown, but dexlansoprazole, esomeprazole, lansoprazole, omeprazole, and pantoprazole, and then lastly, rabeprazole. Again, several of these are available over the counter, like omeprazole and lansoprazole, but drugs like pantoprazole and rabeprazole are still prescription only. So now, based on the relevance of why we study and learn or talk about this drug class, even though it's been around and we see them a lot, not only the drugs that make up, but what are some of their indications that we use these drugs for? Now, I'd like to move us to a table to learn these and see these in the context of other drug classes that make up the category of antacids. Okay, you can see from this busy table, there's 3 sections. There is the top section, which is the H2 receptor antagonist. There's the middle section, which are the proton pump inhibitors. And then lastly, the potassium competitive acid blocker, vonoprazan. Now, tables like this are available for download for your use of studying or sharing or use in lectures if you feel like you need it or it's helpful to you at thisiswhy.health. We have collections, playlists, other tools that we make available. All you have to do is sign up for a free account and you can get access to these kind of things if you find them helpful. Now, you'll notice that the columns are broken down and to the main or common indications. It's not exhaustive of everything possible, but it's the most common uses for these drugs. So you see that you have GERD, dyspepsia, you have peptic ulcer disease, H. pylori, erosive esophagitis, duodenal ulcers, hypersecretory conditions like Zullinger or Ellison syndrome, and then lastly, acute GI bleed, where many times these patients are sick to their stomach, having nausea, vomiting, where a parenteral option is available. And you can see that we have 2 agents there. We put the check marks there to reflect or indicate where these drugs are commonly used. And you can see that GERD and peptic ulcer disease are very, very common amongst the class. You also see that H. pylori is one of the indications for 2 weeks. You don't see that with the H2 receptor antagonist. So this drug class, along with the potassium competitive acid blocker, are the ones that we're going to use for treatment of H. pylori So I got tongue-tied there for a second. You also see erosive esophagitis and GERD, so that goes hand in hand, right? So the problem with acid spending too much time in the esophagus is, one, it can cause erosions, but it can also cause cellular changes that lead to a condition known as Barrett's esophagitis or esophagus. That's a precancerous condition, and so this drug class can be very helpful at protecting the cells from doing that. You can see that esomeprazole and pantoprazole are for acute GI bleeds. Those are the formulations that we have available for us, most commonly used as an IV in these situations. So again, allowing us options as an outpatient environment, ambulatory care environment, and also inpatient environment is good. It also provides some degree of continuity for the patients, where we can communicate this information to them when we're counseling them about why we're treating them the way they're being treated and why there needs to be a certain degree of follow-up. There's that continuity that can be helpful. Okay, now, so how then do the medications, their indications, connect and align with the mechanisms? And I think it's really important. I know some of you may not see the full relevance, but if you follow me here, I think you'll see the value of also having some context of the gross anatomy, and then we'll narrow in and zoom in on specifically the parietal cell in the gastric mucosa, where these drugs are predominantly exerting their pharmacologic effect. But you should put a pharmacologic effect in the context of the anatomy and the indications, because that guides you at some level based on their clinical signs and symptoms and presentation when they follow up with you. That guides us. Are they responding? Are we getting the effect that we want? Because if not, something else is potentially going on or that we could be missing. Okay, let's jump into the anatomy. I'm a firm believer that when you learn a disease state, drugs and pharmacology, that you understand the context of where these drugs are working, also the anatomy they're impacting, for the indications that you're using them for. Because that guides us. It guides us to understand, is the drug getting to the site of action and exerting the desired pharmacologic effect? And if not, why not? Okay? On top of that, it also is helpful to learn anatomy, because if something isn't working right, especially in this context of antacids, there's some bad outcomes. We heard indications like GERD that can eventually lead to erosive esophagitis. You heard a condition called Barrett's esophagus that can be precancerous. We heard the word peptic ulcer disease, duodenal ulcer. The duodenum is part of the small intestine. Why do they get ulcers? And then lastly, why do they develop GI bleeds? What is the deal with the blood flow? Well, that comes back to the anatomy. So it's important to have a framework in the context of the antacids in general. How do they work similar? How do they work different? What conditions are we treating? So that's what we're going to spend some time looking at here now. Please stay with me. It makes sense and it brings everything back together. Please don't bypass this section, because it is relevant to your understanding of the why. Now, we partner with a service known as anatomy.app. Excellent service. You're going to see some great anatomy, three-dimensional structures. They do a fantastic job. We also provide you a link, a referral to that if you need that kind of service for your own knowledge or studying. Again, we highly recommend it. So let's now jump into the board here and look at the anatomy. So first I want to point out some normal anatomical structures. We have the aorta that's coming off the heart and going to the branches that would go to the upper body and then down to the lower body. You also see there is the esophagus, and it comes down through the diaphragm, and the stomach sits below and underneath, tucked up under the curve of the diaphragm. And the first part of this small intestine, which is the duodenum, is right here. Now, why does it matter to recognize this? Well, the esophagus is where that erosive esophagitis is happening. It's also where patients develop GERD. Well, why do they develop GERD? Well, if we zoom in and then also look underneath, you can see that there's an opening in the diaphragm at this location that is helping you to see where the esophagus enters into the stomach. If that band of tissue or that area gets compromised, then acid from the stomach can move up into the esophagus, which it does intermittently, but then we need to get it out. So if it spends too much time up in the esophagus, it's going to cause GERD, and it can lead to erosive esophagitis and eventually lead to a Barrett's esophagus. Now, the stomach can herniate itself up through this hole and stick out on top at this level right here. That is called a hiatal hernia. And with a hiatal hernia, patients can have ongoing symptoms. And that's why it matters, because if you're not responding, it may be because they need a surgical correction of the problem. Now let's take a moment and let's look at some of the anatomy of the stomach and specifically the blood vessels, because that goes back to GI bleeds and peptic ulcer disease. So here we have, you can see the anatomy of the stomach in more detail. Over here is this spleen. You can see that the aorta is coming down and there's a lot of branches coming off. This is the celiac trunk right here. There's a branch going up, there's a branch going over to the spleen. And so these arteries supply large volumes of blood to the tissue. But you also see that we have the common hepatic artery, and then eventually we get down to the gastroduodenal artery. Now it's a smaller artery, but it's feeding the duodenum, the gastrum and the duodenum over here. Well, when you have somebody with a duodenal ulcer, and that blood flow is impacted, okay, so you can see down in here, this gastroduodenal artery down here is feeding the duodenum. So if you have a posterior duodenal bleed, those patients can bleed like crazy and die from that. Obviously, if you impact the gastroepiploic arteries, here in the gastric, you have this, the big curves and the smaller curves of the stomach, and you see all these blood vessels going to it. If we erode through that, then you can cause the blood to leak in there. Well, that's blood coming right off the aorta. It's under high pressure and volume. And so that becomes very relevant to explaining why those conditions become so important for us to manage. Now, let's go to the stomach itself. So when we kind of start to zoom in now, this is where we're going to see the cross-section of the stomach. We're going to eventually zoom in and get to the cells. We have chief cells and parietal cells that make up the lining of the stomach. You'll see here in a second that inside the stomach in this cross-section, there's a lot of folds. And in these folds, you see that can expand. Well, that's so that when we consume food, it can stretch. Right? But down at the cellular level, that's where those blood vessels are coming in from that blood supply we were just talking about, but it's also where these cells reside. Now, think about the anatomy of this. So if we kind of zoom in a little bit more, again, you can rotate around and see the stomach in all of its angles, but let's say we put a band around here, or we remove a portion of the stomach to make it smaller. So in gastric bypass, then we remove these cells. Well, if we remove these cells, we can also remove some of the normal physiology. And so these are where patients start to develop problems with B12 deficiency issues, absorption of other nutrients become a problem. But you also change the capacity of the stomach. Okay, so now that we saw the basic anatomy, we're now going to zoom in at the cellular level, and we're going to look at specifically the parietal cell in the context of how do these drugs work after they make it to the site of action. Okay, so now we've zoomed in and we're looking at a image, generic drawing of the parietal cell. So on this side of the parietal cell over here is the luminal side, okay? It is the apical membrane running along the lumen of the inside. So there's those folds. On the other side is what we call the basolateral membrane. It's the side that communicates and talks with mainly connective tissue and the blood vessels. So the blood flow coming in, feeding these cells. So again, if you erode down and you got a blood vessel coming in here, you can cause a bleeding ulcer. Now there's a couple components on this image that are important for you to recognize. On the luminal side, you see that we have something called the hydrogen potassium ATPase pump. Is a transporter. This is the proton pump right here. This is the proton pump. Here's a proton pump. You got a lot of them. Now, they're the ones that are outputting hydrogen ions. And when those combine with chloride that are being transferred through, okay, then you form hydrochloric acid. And that's what generates the pH, makes the environment more acidic. On the basolateral side, you see we have a large number of receptors and things that turn on intracellular biochemical reactions. Some that activate, which will turn on acid production. Some that are inhibitory and will reduce acid production. There's a balance. So when you look over here, we have acetylcholine that can bind to a muscarinic receptor via the vagus nerve. That's our parasympathetic nervous system. So when we want to eat or we start to eat food, we go into this fed state. That's a parasympathetic response. That means the acetylcholine levels via the vagus nerve are feeding in on that muscarinic receptor. Then we have gastrin coming from the G cells binding to the CCKB receptors. And then you see histamine right here binding to the H2 receptor. H1 receptors reside in other places in the body, typically associated with allergic reactions. Then we have somatostatin and prostaglandins, which are both turning on inhibitory pathways. So prostaglandins become relevant because if you think about drugs like NSAIDs, NSAIDs are known to cause gastric erosion and irritation. They can lead to ulcers, so can aspirin. How does it do that? Why does it do that? Well, we'll go into more detail in another episode, but in short, prostaglandins are inhibited by NSAIDs. So we block this inhibitory effect. That means we're going to facilitate acid production. But NSAIDs also affect the blood flow in through the basolateral side because prostaglandins, specifically prostacyclin, is known to be vasodilatory. So if we wipe that out, we reduce the perfusion coming in. We also reduce the inhibition by the prostaglandins on the parietal cell, and we create an environment or milieu that favors erosion and ulceration. So when you understand some of these basics, then the drugs begin to make sense. Well, what if we want to neutralize just the acid? So you're just having some dyspepsia and indigestion, and you want to solve it quickly right away. Well, the easiest thing that you can do is grab the antacid, over-the-counter antacids like Tums, Maalox, or Mylanta, and just take a good swig, Gaviscon, all those kind of, they will neutralize the gastric acid almost immediately on contact, okay? Now, the problem with that is that it's not long-lived. It's a short effect, okay? That means you'd have to keep repeating the doses throughout the day, which is not feasible and could expose people to other things that you don't want them to be exposed to. Too much calcium, too much aluminum, all these things, magnesium. They cause side effects. So it's not a very effective agent, especially if you have gastric ulcer and need healing. So oral antacids like Tums, Maalox, Mylanta are helpful quickly, but they don't serve for treating underlying problems. That's why we don't see it for H. pylori. That's why we don't use it for ulcers. If you want to get more acid suppression, the next easiest option is the H2 receptor antagonist. It's available, again, many times over the counter, And when you give this drug, you are blocking one of the receptors, not all of them, one. And so you will block this activation, which will slowly reduce some of the hydrogen ions. But like I said, it doesn't eliminate all of them. You still have other things turning on the proton pump. And so over time, the use of H2 receptor antagonists can lead to a condition or development of tolerance, breakthrough acid production. Because you are also not fully suppressing all of this hydrogen ions, you are not generating the gastric pHs above 4 for a longer period of time that's needed to create healing, like a PPI can, or like something like a potassium competitive acid blocker can. You have to do something else. It's not going to work. That's why we want to be careful that if patients are not improving, at some point, we have to change and adjust the medications around. So how did we do that? How did we overcome that? Well, that's where the development of the proton pump inhibitors came, and as well as the potassium competitive acid blocker, okay? They work at the proton pump. It doesn't matter what turns on the cell. It doesn't matter what's triggering it, what intracellular biochemical reaction, it doesn't matter. At the end of the day, it blocks the final movement of those hydrogen ions out into the lumen. And so obviously they're more effective. Now PPIs do that in an irreversible manner. That means they form a covalent bond with the proton pump, and they're there for the life of that pump. Now, thankfully, parietal cells in your gastric mucosa are turning over every couple days. So once you've administered the medication, it may be gone from the blood, but it is stuck on that proton pump for the life of it. That's good. That generates greater acid reduction, reductions in production of it. It makes the gastric pH more alkaline, achieves those goals of greater than 4, and definitely can get up to greater than 6, where if you have active bleeding, you can facilitate some coagulation. It also avoids, there's no tolerance. I mean, it's just check boxes. It's great. It also allows for once a day administration. Now, what about the potassium competitive acid blocker? Well, yes, it works on the same proton pump, but it competes in a different location, and it's a competitive inhibition. But it's a pretty tight competitive inhibition. It has a pretty decent binding potency, if you will. And so the duration can be greater than 24 hours. In fact, it also works on basal acid production, which can be very helpful when you need to heal, especially at night. Now, sometimes we will use combinations of medicines together to maximize the effect, especially in very difficult to treat patients. But these two drugs right here, drug classes, are the ones that are going to exert the effect to provide treatment for H. pylori over a 2-week treatment. They're very effective for treating peptic ulcer disease and duodenal ulcers, especially if they're actively bleeding, because you've got to get that pH above 4 and specifically above 6. So I hope that brought together how the drug classes kind of interact and work with each other, how they're similar but also different in many ways. Okay, so now that we have a good framework of the anatomy and the physiology and also what's going on pharmacologically with these drugs at the point of action, it's important to also now step back and go back to the pharmacology. So mechanism is part of the pharmacodynamic effect. But we need to talk about a few pharmacokinetic parameters that may influence why we pick one agent within the class, how we dose them and use them. So let's jump to another table to help guide us in that. So again, similar to the indications, we have a table for the drug category antacids where we break it down and compare it, the PPIs, to your H2 receptor antagonists here on top, okay, and then your potassium competitive acid blocker on bottom. You know, it's good to see how are they similar, how are they different. What are their profiles? That guides us in picking one agent over there. It also goes back to explaining why certain drugs, because of their pharmacokinetic profile, are better for certain indications. So when we look at the oral bioavailability, which is in this column here, okay, we can see that overall, most of these agents have a good oral bioavailability. Most of them get absorbed pretty well. There's a few exceptions. Omeprazole is not that great. Rabeprazole is not that great in food. Can also be limit the rate of absorption and cause a delay. But overall, fairly well absorbed. Now, even for those that have not such a bad or a good absorption, you might say, well, why would I use that? I mean, is that a problem? Well, not necessarily. I'm going to bypass the metabolism for a second. I'm going to go over to the onset of action and then, more importantly, this half-life. Now, because I want to put it back in the context of the mechanism so that we can understand, well, why do these drugs offer 24 hours of antacid production when they may not fully get absorbed, when their drug half-life in the body is only a few hours? Well, it goes back to the mechanism. Remember, that's an irreversible inhibitor of the hydrogen and potassium ATPase pump. So for the life of that pump, it is blocked. So yes, it might not be in the blood anymore, but it's attached to that transporter and it's holding it tight until basically the body remakes another one or replaces the parietal cell. So when you look at the onset, it's relatively quick. Now you'll see drugs like dexlansoprazole have a biphasic dual phase absorption and also onset. There's an initial onset in the first 1 to 2 hours, and then there's a delayed 4 to 5 hours. And that is strategic in efforts to try to mitigate some of that acid production and maintain the gastric pHs above 4 as long as possible. Because that's that metric for success in healing, right? So above 4 for healing, above 6 for coagulation to be favored, especially in an actively bleeding ulcer, which can be, like we saw in the review of the anatomy, can be very relevant. So when you have a short half-life but a long duration of action, it should make sense in the context of the mechanism. And in this case, remember, they are covalent irreversible inhibitors. The next thing that I want to point out to you is their pathways of elimination. You will see that pretty much all of these agents depend on phase 1 metabolic pathways for metabolism. Remember, phase 1 is an oxidative reductive pathway, whereas phase 2 are conjugated pathways that make drugs more hydrophilic for elimination. So oxidative reductive pathways include the cytochrome P450 enzymes. And you can see that 2C19 is very common in these agents, being a substrate. And so that can be important and also relevant, especially if they offer some inhibition of 2C19. Because there are drugs like Clopidogrel, which is known as Plavix, used as an antiplatelet drug for their patients with cardiovascular disease, sometimes also stroke. And that drug requires it to be metabolized through cytochrome P450 system, including 2C19, to become functionally active. So if you block or interfere with that enzyme, you could affect the metabolism of other medicines. And that's why it can be relevant. Now, the other thing that's relevant as it relates to 2C19 is that this enzyme, like a lot of enzymes and transporters and other proteins in our body, they can be subject to genetic polymorphisms. Those are the variations between us. Okay, so what? Who cares? Well, some people can make 2C19 that works like it's supposed to. That's the normal variant, right? It's the wild type. What about those who are slow metabolizers? It doesn't work. Well, then it may cause drugs to stick around a lot longer. What if it's you're an ultra fast metabolizer? Well, they can basically chew through these medications so fast that the pharmacologic effect is not there. How do you know if someone has that variant? Well, you got to test them. Do you have to do that to use these drugs? No. But if you're not getting the desired pharmacologic effect and the clinical outcomes that you would anticipate with a drug class that works like this and is used for that many indications, then you need to probably stop and ask yourself, why is this drug not potentially working? Is it compliance? Is it adherence? Right? And if those things are removed from the equation, then it may be genetics that is influencing it. So those are some important, relevant things to keep in mind. Many of these things become easy test questions, but it also points to why we administer these medications once a day in most cases. H. pylori and SF, you use it twice a day, or in certain hypersecretory conditions, we do see these drugs being used twice a day to maximize the overall inhibition of that proton pump. Hey, so we all know that no medicine is perfect. There's side effects, there's drug interactions that lead to monitoring parameters and counseling points. So let's talk for a moment about some of the common adverse effects or side effects associated with the PPIs. And I want to jump back to a table to help us wrap our minds around this. Okay, so this table summarizes the potential, I use the word potential because not everybody is going to experience that. Over here on the far left, the potential adverse events. You can see that we have infection, and that it could include pneumonia, specifically aspiration pneumonia. You can also cause some degree of colonization of the intestines that lead to enteric infections, especially in the context of other meds being used like antibiotics, so then C. diff is a risk. But you can see also infection down here at the bottom here is spontaneous bacterial peritonitis in patients with cirrhosis. Again, we don't typically want these patients getting infected. It not only can cause encephalopathy, but it can cause then hepatorenal syndrome and set up for bad outcomes. So infection is relevant. Okay, so these are potential. And then the second column, you see the risk factors. Who's at risk for these things? And then the third, what are some of their causes or explanation? Try to summarize that for you. Again, this table, along with other tables, are available for you at thisiswhy.health. So let's talk about the infection. I mentioned aspiration pneumonia. I mentioned C. diff. Who are those patients? Well, remember, they're going to typically be hospitalized, bedridden patients. So you can also see these in nursing home, long-term care facility, where patients are aspirating after colonizing their stomach because that acid is gone. Remember, we need acid for normal physiology and protection. One is it helps us to digest food. Number two, it also protects us from things that we put into our mouth or that's contaminated in the food. So if you remove that acid, you then allow or increase the potential of colonization that would not normally be there of bacteria. So your microbiome essentially is changing. And that can allow for opportunistic infections to set up shop, okay, and then cause new problems. And so that's due to the change in the intestinal and gastric pH. Second, you see here are some nutritional issues. Magnesium being low, and also B12 being low. Okay? Magnesium becomes relevant because low magnesium can be associated with another electrolyte abnormality known as hypokalemia. Magnesium serves as an important cofactor that helps transporters move electrolytes in and out of cells. So remember, potassium is the major intracellular cation. That means it normally is residing inside the cell. Well, how does it get in there? Through a transporter. Okay, so it needs that functioning transporter. Well, magnesium sometimes serves as a cofactor to keep that transporter working. Well, so what? Why does it matter, Dr. Busti? Why are you spending so much time on this? Well, when you find a patient who is low in magnesium, they may also be low in potassium. And if you're low in potassium and you want to replenish or replete that potassium, you have to correct the magnesium first, or you're not going to be able to move that new potassium you're administering to the patient into their cells. Remember, it's an intracellular cation. Yes, it exists outside the cell, but it is the major intracellular cation. So you've got to replenish total body potassium stores. So you have to correct the magnesium first, then you can fix the potassium. And you're like, okay, that's helpful. Well, why also is it relevant? Because hypokalemia, low potassium, and hypomagnesemia, low magnesium, are both known to be associated with cardiac dysrhythmias, specifically prolongation of the QT interval, which results in QRS widening that results in QT prolongation that can lead people to develop torsades, which is a life-threatening ventricular dysrhythmia. So it matters. And lastly, as it relates to even the bone, which you see down here, magnesium is an essential component of bone, along with calcium, collagen, other connective tissue. So magnesium is relevant. The problem with magnesium when you're doing workup and managing patients is it's not part of any lab. You got to order it specifically. It's not a part of a basic metabolic profile. It's not a part of a comprehensive metabolic profile. You have to add it on. And I can't tell you how many patients I assess, especially in the emergency department, where I see these electrolyte abnormalities, and a lot of times when I'm receiving sign-up from my colleagues and stuff, they haven't checked. And so they just sometimes miss that point because you have to put the order in. It's out of sight, out of mind. It's another click of the button if you're using EMRs. I wish they would just put it in the CMP, but they don't. Okay? So you got to pay attention to these things. It is very important clinically and explains why patients can develop some bad outcomes if you don't correct it appropriately. Now, vitamin B12 is something that requires binders, also requires intrinsic factor in its movement from when you put it in your mouth as part of the food to where it gets absorbed in the small intestine. It needs a gastric acid environment in order to do that. And so you can compromise that, which can lead to a macrocytic anemia. It can also lead to, if you deplete the body over chronic use, to lead to demyelination of the posterior column of the spinal cord that can lead to neuropathy and weakness. I mean, that's legit. I've seen it, especially in patients who are vegan. True vegans that don't eat anything from animals have to supplement or they will become deficient. And that can be significant complications from it if you don't. Now the bone density shifts have to do a little bit with the calcium absorption from the acid changes. It also may in fact impact the vitamin D, but you're also impacting magnesium. So bone, again, is not just calcium, it's magnesium, collagen, and calcium. All those things are all present. Okay, and so healthy bone needs all of those components. So all of these things can be impacted. Now this SBP is in cirrhotic patients. So these patients, especially on PPIs, can colonize, that can translocate, and then cause a peritonitis. Well, that is known to increase the risk of hepatorenal syndrome. If you've ever studied about hepatorenal syndrome, these patients have a high risk of mortality. So this is why it matters to learn some of these side effects and adverse effects, because they also become part of our monitoring parameters. It just makes sense of it. You shouldn't have to memorize it. All right, now let's talk a little bit about drug interactions. I'd first like to talk a little bit about those drugs that require an acidic environment for their absorption. Okay, they need acid. The first one that you need to keep in mind is rilpivirine. Rilpivirine is a drug that is used in the management of HIV. It's an NN-RTI. That is a nucleoside reverse transcriptase inhibitor. And it's going to be used in combination with other antiretrovirals. It's not going to be used alone. So when you're on this medication, you need it in the body. Its effects are concentration dependent. Otherwise, resistance can develop. And we don't want that. So an antacid can cause failure of the management of HIV and even resistance that now requires the patient to be put on a different antiretroviral regimen that may cause them to lose viral control. Not good. So a simple antacid can be very, very relevant. Well, it's not the only drug. Rilpivirine is not the only one. Certainly an important one. But there's another HIV drug called atazanavir. It is a protease inhibitor for the treatment of HIV. It also requires an acidic environment. Again, PI-based regimens. It's a 3-drug regimen at minimum. Okay? You need that medicine there in order to prevent resistance. Itraconazole capsules, not solution. Tyrosine kinase inhibitors used in cancer and oncology. That is dasatinib and erlotinib. And then there are drugs, like I mentioned earlier, that can be impacted by the cytochrome P450 system, specifically 2C19, like Clopidogrel. Okay? So these become very relevant drug interactions that warrant our awareness when we're doing a medication use assessment, when we're reevaluating the patient at follow-up. Make sure that nothing new has been started or changed in their regimen. All right, now that we understood a little bit about the adverse drug events and drug interactions, what about the monitoring parameters? Again, it should make sense, guys. This is not rocket science. We don't need to make this complicated. Why are you using a PPI to begin with? So you should ask them about those symptoms. The dyspepsia, the reflux, the esophagitis, many times it's substernal chest pain, right? Because if they're not responding, either the drug's not working, maybe it's genetic polymorphism, maybe it's compliance, or maybe you have the wrong diagnosis. Patients with indigestion could also be having a heart attack. In fact, it's known that 1/3 of women will present to the emergency department with an active heart attack and not have chest pain as their symptom. They'll have indigestion or something else. So you have to be vigilant to monitor, understand the anatomy, think about what you're doing, make sense of it, and manage the patient. That is the how. Now, guys, I know that I'm throwing a lot at you, and I know it can seem a little overwhelming at times, especially if you're new to some of this. But that's okay. Don't try to memorize everything. Try to understand it. Let it soak in. You may have to listen to this more than once. In fact, I recommend you do that. Let it soak in. Apply it. Go put it to practice. Pay attention to what your patients are saying. Come back and listen to this again. It starts to stick. But think about your monitoring parameters of labs. You heard about magnesium. You heard about calcium. You heard about B12. So maybe you need to check them, especially if patients start to develop problems. Magnesium might be something sooner than later. I mean, to get deficient in B12, you got to take it for a while. So 2 weeks is not going to cause B12 deficiency in most people. All right? So long-term chronic use can lead to that neuropathy that we're worried about, or a macrocytic anemia. Okay? What if your patient has osteopenia and they're at risk for osteoporosis? Well, you need to get a DEXA scan. You need to keep that vitamin D level appropriate, keep their calcium, magnesium levels appropriate. Yeah. What about special populations? Well, we talked about patients on tyrosine kinase inhibitors. What if they have cancer? We don't want a stupid drug like omeprazole and some other PPI, not to pick on omeprazole, sorry about that, I mean, any of the PPIs, to cause therapeutic failure, someone's cancer. I mean, could you imagine telling someone that? I'm sorry, your cancer came back because we gave you an antacid. Sorry. What else is going on? You know, I mean, we cannot function and work like it. We got to pay attention to what we're doing. What we do matters. That's why I'm spending so much time focusing on these things. What about patients who are immunocompromised? Risk of infection. So you heard about cirrhosis. You heard about the long-term care facility patient, the bedridden patient, or the hospitalized patient. We don't need them getting more infections. So pay attention to these things. If someone is on a medicine, by the way, like this class, see this 1,000 times. Like, why are you taking that medicine? And they're like, I don't know. Well, how long have you been on it? Decades? Okay, are you having symptoms of anything? No. Did you have any? Okay, so that sometimes stop the medicine. I mean, for crying out loud. It's not wrong to stop a medication when it's not indicated anymore or it was used for its purpose and it's now done. Okay, now you would hope that your primary care doctors are doing that. That's the job of those folks. But we should all stop and ask so that we do the right thing for the patient and counsel them. So as it relates to counseling, there are a few points that are relevant. We talked a little bit about the drug interactions. Compliance is key, especially if you're treating H. pylori. Or you have an active ulcer and you need it to heal. We need that gastric pH above 4 for sure to facilitate healing. Okay? Now, if they start new medications or they're a patient with cardiovascular disease, they need to know about the risk of drug interactions with certain medications, like Clopidogrel. Now, if they're using it for GERD, it is ideal to take it 30 to 60 minutes prior to the first meal of the day. Okay? So these things should make sense to the why and the monitoring parameters and the side effects. All should start to be lining up to where you don't have to memorize it. It just makes sense. Whew. Again, guys, I know a lot here, but remember, knowing why better equips all of us to be able to adapt to those unusual clinical scenarios. They also help us to anticipate complications and come up with innovative solutions at the bedside, right? And or in the clinic so that we can take care of our patients. That's from the what to the why for the purpose of improving the how we manage patients. Check us out at thisiswhy.health. That's where we have collections, playlists, newsletters. You can get access to the tables, study tips, and guides and things that we cover in these lectures. Certainly, if you're watching this on YouTube, please like it, subscribe. It helps us out, but it also helps you to keep up with other new topics that are coming out. And with that, let's close this topic. PPIs, huge. Answer to problem. That tolerance with the H2 receptor antagonists was a problem. And so PPIs address that. They also address the need to get the gastric pH above 4 and even 6. So when in our acute cases, for the acute GI bleed patient, we have options, not just PO, but IV. So again, this gives us options in the inpatient, outpatient, acute use, chronic use. These drugs are available generically. Some of them are available over the counter. They overcome the tolerance of H2 receptor antagonists and are fairly well tolerated, but they have a few adverse drug events or side effect risks that we do need to keep in mind. So I hope that you found it to be useful. We'll see you next time at the next topic review on This Is Why.